Hi, good morning. My name is James Cornwall. I'm one of the vascular surgeons at Mount Sinai Hospital. Today I'm going to be talking a little bit about aortoiliac occlusive disease, algorithm, devices, and techniques to tackle the complex cases. I think as a fellow or a trainee, these are really great cases. You can be involved in the preoperative planning of the case. If you have imaging beforehand, a CAT scan you can look at, come up with a plan, and then during the intervention, you're really using the whole armamentarium of endovascular techniques and devices that we have. And then also, as you just saw from Dr. Murphy, our interventions are very durable and effective, and so I think that sort of makes these really, really great cases. So really, as far as the algorithm goes, it starts with, when you're meeting the patient, and I think one of the most important things is assessing the patient's overall preoperative functional status and their frailty, because in combination with the indication for the procedure, as far as whether or not this is a patient with lifestyle limiting claudication or a patient with critical limb ischemia who has ischemic rest pain or non-healing ulcers, those are really going to determine how aggressive you're going to be in intervening on the lesion. As far as imaging goes, preoperatively, I like to have a CTA on all these patients. You want to be able to evaluate the infrarenal aorta all the way up to the renal arteries, and that can help kind of evaluate your access options as well as the common femoral artery and so on. There's classification systems, which you guys have already heard a little bit about. So the task, essentially it goes A through D, A being for unilateral, shorter, less occlusive lesions, all the way to D being longer segment occlusive disease. And as Dr. Murphy mentioned before, endovascular interventions are well established in all of these, and that's been happening over the course of the past few decades. So in regards to the access options preoperatively, you want to evaluate the common femoral artery, that's the most common one, and how much atherosclerotic burden there can be. Sometimes you can have a staged procedure with a femoral endarterectomy, a patch angioplasty, or it can be simultaneous with some sort of hybrid procedure where you're repairing the femoral artery and then accessing the patch and treating the lesion from there. Based on how the femoral artery looks, you're going to want to know what size sheath you're planning on using and what size or what closure device you're going to be using, because ultimately that will all be really influenced by how healthy of an access site you have. For common iliac lesions, I generally prefer to access the ipsilateral side. For external iliac artery lesions, I generally prefer to use the contralateral side going up and over, but there's nothing very dogmatic about this. And then I have a really low threshold for bilateral femoral artery access, even if it's just having a 4 French in the contralateral side to shoot diagnostic imaging. I certainly don't shy away from that in these cases. And then in more complex cases, you can use an upper extremity, either radial or brachial artery access, preferably the left side or the left arm. And obviously, preoperatively, you want to have a sense for the patency of the subclavian artery, because that's a very common area for atherosclerotic disease and occlusive disease as well in our patients, even sometimes without symptoms. So you can either see that on a CTA if you have one of the chest, but also being able to just examine the arm preoperatively, assessing for pulses and blood pressure in both arms. Once you're in the procedure and you have access, I always make sure to take good pre-intervention imaging. So from your femoral arteries, you want your ipsilateral oblique to see the takeoff for the profunda. I always shoot runoff before the procedure, because if there's anything about the pulse exam after the procedure while they're still on the table that's inconsistent, you want to be able to shoot runoff after the intervention and be able to see sort of if there's anything new that's developed. As far as evaluating the iliac arteries, I like to shoot a contralateral imaging, contralateral oblique, to evaluate the takeoff of the hypogastric, and that's sort of before we even intervene. As far as crossing the lesions, once again, for common iliac artery, it generally will be ipsilateral. I generally start off with just an 035 guide wire, glide catheter. Floppy is initially what we do, but we will go up to various 035 wires, or sometimes an 014 system as well, to help cross those lesions. For contralateral, I normally go up and over with an Omni or a Sauce catheter. and that's what we'll use to go across the lesions. Once you've crossed the lesion, it's always important to confirm that you're intraluminal with your catheter, so we'll remove the wire, we'll puff contrast, or you can confirm that with IVUS imaging, as you heard in one of the earlier talks. Sometimes if you're not intraluminal, once you've crossed the lesion, you can be in a dissection plane. You can either pull your catheter back and try to get intraluminal, but there are re-entry catheters. The Outback is the most common one. I primarily use this in femoral popliteal disease, but it can certainly be used in aortoiliac disease as well. And essentially what this is it's a catheter. Here you see sort of there's an upside down L-shaped, and you advance it over the wire, then you pull the wire, and you reinsert the wire in another port, and then this kind of spears out laterally, and that goes through the intimal flap, and then it's a bore needle, so you can advance the wire through that and regain entry into the true lumen. And I think this is really helpful in complicated lesions where you're unable to track through the true lumen, and you keep finding yourself in a dissection flap. Some people routinely will measure pressure gradients across the lesion. I think if there's a pretty flush long segment occlusion, you don't need to confirm the hemodynamic significance of it, but certainly there are certain pullback techniques you can do by connecting the arterial line to the backside of your sheath and pulling back through the lesion over the wire. And then, as Dr. Murphy mentioned before, calcification certainly can complicate this, complicate your treatments, and can certainly cause rupture in the worst case. And I think that that's something that you have to be really mindful of and know about preoperatively. So if this is something that happens in the middle of the procedure, you're not running and looking for the stent that's on the other side of the hospital, depending on where you're practicing. And it's important preoperatively, if you expect this is going to happen or you think that it's a possibility, to make sure that you have all your sheaths in the room of appropriate sizes with the covered stents that you're going to be using. I must have relived some past trauma when I wrote this slide. I apologize. So all the caps and exclamation points are just sort of reconfirming how important it is at these times, to have maintain your wire access, be constantly communicating with the other members of your team, and then always have all the equipment you need available in these cases, because ultimately, RP bleeds and extravasation can be life-threatening. So here you can see there's a treatment in a right iliac artery, and you can see in this imaging, there's extravasation of contrast. There's obviously some retroperitoneal bleed, and it's persisting after further treatment, and then ultimately a covered stent is placed. And here you can see on completion imaging that there is no further extravasation. So for sizing, I use minimal oversizing for very calcified vessels, and I measure that based on the size of the adjacent artery based on CAT scan or intravascular IVUS. For the length of the lesion, you can use a markered catheter with your diagnostic imaging to get a sense for it, but also a lot of our machines now have calibrated imaging, and so you can just measure that directly from your diagnostic imaging. And then balloon inflation should be gradual. Make sure you have, if you don't have an anesthesiologist in the room, make sure you're visualizing, some sort of arterial line or checking your blood pressure with in quick intervals. And then ultimately, for balloon expandable stents, always advance the sheath past the lesion before you load the stent. So for the type of stents I prefer balloon expandable stents in the common iliac, just because they have more radial force and more exact deployment, because you don't want to cheat across the bifurcation and compromise the other leg. And then for the external iliac, because of the tortuosity and the flexibility, I prefer self-expanding stents. And then anything that's irregular or ulcerated, or as I say, anything that looks at me funny, it's going to get a covered stent. And care must be taken so that you're not cutting off any side branches if you are using a covered stent. So here's a few cases. The first one is this unfortunate gentleman who had an above-knee amputation that wasn't healing appropriately. He came in from an outside hospital. He had no palpable pulse on the ipsilateral side of his amputation, and so he got a CTA. And here you can see, kind of going left to right, top to bottom, This is a slice where you can see has significant infrarenal aortic calcification. After the bifurcation, you can see the right common iliac is occluded, and the left common iliac is patent. And then as you go further down, there is flow in the external iliac artery and the hypogastric, and this is sort of where it reconstitutes. And then in the final image, you can see at the right common femoral artery, there's significant atherosclerotic and even some calcium on the right side. So what we did was a hybrid case where we did a femoral artery endarterectomy and patch angioplasty, and then we accessed the patch directly, and we placed a covered stent in the common iliac artery. So here you can see this is our initial diagnostic image from our patch on the right side. You can see the patent external iliac, patent hypogastric, and you see significant calcium on the imaging, and then it's completely occluded. We were able to get through the occlusion with an 035 catheter and an 035 wire, almost certainly in dissection plane based on the shape of the catheter in this image. However, we were intraluminal, as you can see, because contrast is flowing through the infrarenal aorta and the left common iliac. So we advanced, so we pre-dilated with, I think it was a 3 or 4 millimeter balloon. If we were in the calcium, this would have been a really good case for IVL, as Dr. Murphy was mentioning before. And we advanced our sheath past the lesion. So you can see here's our radio-opaque tip of our sheath. And then we loaded in our VBX, or our balloon expandable covered stent. And this is our completion image. Ultimately, he healed his above knee amputation and was able to go off to rehab. The second case is a patient came in, a young patient who was actively smoking and presented with acute ischemic rest pain and ulcers. We were concerned she was having some sort of embolic disease. So here you can see in our diagnostic imaging, she has a patent infrarenal aorta. Here on the right side, which is her symptomatic side, you can see the patent common iliac artery. This is the hypogastric, and then the external iliac artery is occluded. And then this was just a runoff to show that she had patent 3-vessel runoff. We were able to get across the lesion. The wire went very quickly and very easily. So we confirmed our suspicions that this was more of an acute thrombotic event. And so you can see down here in the bottom of the image, these are the radio-opaque markers on a spider filter. So over a filter wire, we passed a penumbra thrombectomy device. Ultimately, we confirmed with IVUS that this was secondary to a dissection in our iliac artery, and we placed a self-expanding bare metal stent. For sake of time, I'm just going to continue going. I think there are some cases that if the whole infrarenal aorta is occluded all the way up to the renal arteries, these sort of is the forefront of where we have endovascular interventions, and I think sometimes these patients may require an open intervention, but that's an exceedingly rare case. So these are my tips and tricks, and these are some potential downfalls, which you're going to hear about later. So thank you very much.